Our next speaker is, hopefully I pronounced your name correctly, Dr. Shailendra Das, or Das? Das. Dr. Das is an assistant professor in the Department of Pediatrics at Baylor College of Medicine. His specialty is pulmonary medicine. Dr. Das serves as director of the Primary Ciliary Dyskinesia Center at Texas Children's Hospital in collaboration with physicians from other specialties. PCD is a rare lung disease that causes recurrent lung and sinus infections. He also cares for patients with complex airway disorders, including those that need bronchoscopy, as part of aerodigestive program. He is also part of the lung transplant team at Texas Children's Hospital. He received his DO from the University of North Texas Health Science Center and completed his internship and residency at the University of Texas Medical School in Houston. His fellowship was completed in pediatric pulmonology and was completed at Baylor College of Medicine. His talk today is going to be on the pulmonary late effects for neuroblastoma patients. Dr. Das.
Thank you, Pat, for the kind intro, and thanks for the invitation to speak today on pulmonary complications of neuroblastoma treatment. Great. Okay. So I was a member of the advisory board for a company that makes anti-fibrotic or anti-scarring drugs for lungs, and that actually has some pertinency to this talk as well. I am not a pediatric oncologist. In fact, I'm going to turn to you guys when questions come up about certain protocols, as you guys know 100 times more than I will about protocols. However, the protocols that were mentioned in the previous talk do have a little bit to do with some of the complications that we see, and that'll be important as we go on as well. So I was born and raised in Houston. I never lived outside of Texas. I'm a huge Houston sports fan, and I know the Astros cheated in 2017, but they still won, so I'm happy about that. Sorry, there's no kids in the room, so I can say cheaters do sometimes win. And 2022 is great as well. I've been practicing medicine, or pulmonary medicine, after my fellowship ended. It's over 12 years, but I still consider myself young in some ways. I have interest in lung transplant. I was a part of the lung transplant team for 7 years, and that's where I actually became interested in complications of cancer therapy. We saw a fair number of patients that were referred to lung transplant years after their cancer treatment, specifically actually neuroblastoma. As Pat mentioned, I take care of patients with airway disorders as well. And we have actually a national group for complications of lung fibrosis and lung scarring after cancer and BMT therapy. And we actually meet monthly. And we had our national meeting for the Thoracic Society, where we have subcommittee meetings last week, actually. So we met up, and we have plans for a webinar and symposium at next year's conference. Now, I know what I'm going to talk about for some is sensitive and can be triggering. You've been through cancer therapy. Now you have these high-risk related complications. And so I do want to start with a case, but this is a case that we're all too familiar with. This is an 11-year-old male that comes to pulmonary clinic for shortness of breath and abnormal lung function tests. Has a history of stage 4, high-risk, poorly differentiated neuroblastoma with an unfavorable history 6.5 years prior to that pulmonary visit. They're treated according to a COG protocol, with high-dose cyclophosphamide, topotecan, cisplatin, etoposide, doxorubicin, and vincristine. They eventually had autologous peripheral stem cell transplants twice, and along with the conditioning regimen actually before their first stem cell transplant, and then had radiation therapy. But of note, I think it's important to mention it now, the radiation therapy was to the pelvic region and the abdominal region and not to the chest region. They also had immunotherapy. They came to long-term survivors clinic, and I'll start saying LTS for short as we go forward, for long-term survivors clinic 1 week prior to their pulmonary visit, and they were noted to have increasing fatigue, progressive shortness of breath. Of note, they also had a dry cough for over 2 years. And now he's complaining that he gets more tired climbing stairs or playing with friends. And this was new for him as well. Let's see if I'm under the weather too. Excuse me. I want to point out, do we have a pointer that we can use? Okay, thank you. Oh, I gotcha. Okay, thank you so much. So as you know, this first graph on the left is a weight chart, and you can see that the weight over time is just starting to stay stagnant and not grow, and that's important from a lung standpoint. Whenever we see that, we start to worry. Now, there's other conditions that can cause this, but we start to worry that a child is using all their calories to help them breathe and do their activities, and whenever we see that, we start to get really concerned. The table on the right is actually pertaining to the child's lung function. I'll just quickly looking at that second number, the FEV1 stands for how much air you can get out over the first second in a volume. And then the top number is how much volume you get over time. And you look at how low they are. So predicted values should be anywhere from 80 to 120 normal. And these values are very low. And we call this restrictive lung disease, which I'll get back to a little bit later. This is a severe restriction. So that's just to help introduce the topic of pulmonary complications of neuroblastoma therapy. Now, the reasons can be multifactorial and multifaceted for a number of reasons. Some of these relate to the specific chemotherapy regimens that are used. I know we had a wonderful talk about high-risk neuroblastoma and the chemotherapies that are used. We tend to think that there's a couple of drugs, although not systemically studied, that are the cause of some of the things we see in the lungs. Radiation therapy, and we usually tend to think of thoracic or chest radiation. So when you have radiation to the abdomen, that shouldn't be the cause of a complication. And in fact, that first case, the child was referred to us for the thought that this was radiation-induced injury, but our team and our surgeons pointed out that the child never received chest radiation, so something else is going on. The conditioning used for autologous stem cell transplant, busulfan was mentioned in the previous talk, and busulfan is known to induce scarring or fibrosis of the lung as well over a long period of time. Recurrent infections and immune dysregulation. This can occur during and after and be sequela, where bacteria just kind of thrive in the environment of the lungs afterwards. I put this up there. This is all complications in a paper published a few years ago. When we look at the lungs, and I'll kind of come to the medical data every so often, but we look at the lungs specifically, and we see in a cohort of patients that there's about a 70% odds risk, or 1.7 times odds risk of having any type of pulmonary complication, specifically any type of changes in lung function over a long period of time. This is probably the most important slide I can present, is what to do when do you, as parents, as family members, start to say, hey, maybe I need to see a pulmonologist, or hey, something isn't right. These are the things that you're going to talk to your LTS groups about. These are the things that hopefully your LTS oncologist and team acknowledge as well that you're bringing up. So any changes in exercise ability or tolerance, and that's actually a number of our patients that come in, hey, I used to play basketball with my friends, I can't do that anymore. Or a more common one even is, hey, I used to go to class in the 5 minutes I have to go from one end of the hospital to one end of the school to the other, and I'm no longer able to do that, and that's important. Or a change in just simple daily activities, climbing upstairs, things like that. Shortness of breath, anytime you have kind of persistent shortness of breath, not related to a cold or anything like that, but that just persists over time. A new onset cough, especially that dry cough that just tends to linger over time. It doesn't get better over a 4 or 6 week period. New asthma symptoms, and I put asthma in quotes. As a pulmonologist, we're very stringent on what we call asthma per se, but a lot of times what someone does is they go to their PCP, their pediatrician, and their family doctor, their long-term survivorship group, and they'll notice symptoms that they're put on an inhaler for, and if that inhaler's not helping, that's one indication to say, maybe I need to see a pulmonologist. Recurrent pneumonias or respiratory infections, and then chest pain, especially if it's new onset, sharp chest pain, I think that's worth a consideration for at least a chest X-ray, but sometimes a referral to either us or a cardiologist, depending on the reason. Again, how often this does occur? I periodically put this in the talk just to kind of talk about it. The lung manifestations are relatively rare. In this study that looked at 63 survivors of neuroblastoma, about 1 in 5, basically 19%, had pulmonary abnormalities. I'm going to come back to this, what restrictive and obstructive mean, but You can kind of, that's blocking it, but you can kind of see that both occur in pulmonary patients and neuroblastoma survivors, with more patients having restrictive abnormalities. And that's actually kind of where I come into play with the lung transplant side. There are a number of chemotherapeutic agents that are involved, and this is not meant to be looked at really closely, but that are involved in side effects, specifically pulmonary toxicities. We actually, when we train our team and we talk to postdoctorate fellows and new faculty, there's actually a websites that we can look at to see what drugs affect, how drugs can affect the lungs as well. And so this lists a lot of things that can be associated with pulmonary disease. Specifically, I look at the left side where it talks about some of the chemotherapeutic agents that we use in neuroblastoma, actually. I mentioned the recurrent infection and immune problems. This can relate to the suppression of the immune system during cancer care or during BMT care or afterwards. So during treatment or after, anytime you suppress the immune system, bacteria tend to thrive in that environment, or other bugs tend to thrive in that environment. And that can lead to bacteria living or colonizing in the lungs over a long haul. This bacteria colonizing can lead to recurrent infections and eventual scarring, or what we call bronchiectasis, or damage to the lungs, where you see mucus just kind of plug up an airway and create a dilated airway, which creates its own cycle of recurrent infection, because that allows an environment for the bacteria to thrive as well. And so a lot of our patients, for different therapies related to cancer care, do end up with both bacterial infections and atypical or fungal and different types of infections that we see even chronically after their cancer care. This other study looked at 48 survivors of high-risk neuroblastoma and followed their lung function over time, again showing this obstructive and restrictive lung diseases. This study specifically looked at high-risk neuroblastoma patients that underwent total body irradiation prior to a stem cell rescue, and looked at if there was a difference between patients that underwent TBI and those that didn't go total TBI, and found no differences in lung function between the two groups. And I think that's important to note, that we tend to think of radiation disease when it comes to stem cell rescue. Could that be a possibility for their lung issues long term? And we see mostly that this is not the case in this study, as an example. And this was studied out of published out of CHOP. It did mention that the restricted lung disease had an association with dosage of cyclophosphamide and ifosfamide, which I'm going to talk about to end this talk as well. And I finally define obstructive and restrictive lung disease, and I think it's important that that we look at this when we see patients in LTS clinic. I'm going to pause real quick. How many family members for their child have seen a pulmonologist in the past? Okay. And then how many in LTS get lung function every year when they do LTS survivors? Okay. I check to challenge the notion that I hope that as we grow our LTS survivorship groups in different places, we're at a large children's hospital. I know our previous speaker is at a large children's hospital where we actually do lung function at every visit, and we see our patients every 6 months to a year. But I would ask that other LTS institutions do start to do lung function testing more frequently and often, so that we can identify patients earlier on. And so there's two types of lung function findings that we'll see. The first one is obstructive lung disease. Think asthma, think COPD or emphysema when you think of this. This is difficulty getting air out. So imagine you have a balloon that's inflated and you're trying to squeeze it out. It makes that musical noise, that high-pitched noise. That's what you hear with wheezing. Wheezing is that high-pitched kind of trying to get air out noise. And this is often managed by inhalers or sometimes steroids. On the other side of that, you have restrictive lung disease. And restrictive is, imagine you're unable to blow up the balloon. It's not getting air in completely. There's reasons for that as well that can occur, and this is going to be important for our for LTS clinics as well. Think chest wall restriction. So that can be related to radiation-induced injury, abnormal growth, bone health as well. Think lung scarring. So this is where the lung tissue is damaged due to some of the chemotherapy that's used. So we call it fibrosis. or muscular weakness, which can occur for a number of reasons related to your child's ability, to take care of themselves during their cancer care and during the therapies they're doing. This is often managed by steroids or other medications to help and try slow progression. Specifically, if you have fibrosis or lung scarring, the way to take care of that is to try to slow that progression down by using certain medications. This is actually one of the few pediatric studies that looked at pulmonary complications in high-risk neuroblastoma, and looked at looked at a number of patients 39 patients that had lung function testing done, and found a third of those patients had clinically respiratory symptoms, so cough, congestion, exercise symptoms, but quite a bit more actually had changes in lung function. And so we see on the fourth line where it talks about obstructive lung disease in 8% of patients, and actually had restrictive disease in about 40% of patients right there. And so this is actually important to acknowledge that you may not have the symptoms, but that's why I think it's important to get lung function testing and kind of identify patients early that may need to be seen by a pulmonologist and followed with a pulmonologist regularly. Every patient that actually goes through LTS, specifically under certain COG protocols that has evidence of restrictive disease, is actually seen by one of us in pulmonary clinic every 6 months to a year and followed. And there could be nothing going on. And thank God there's a number of patients where I say, it's okay, just keep following along. And so it doesn't require any intervention. But we want to be watching those patients more closely. And in their cohort, they had 8 patients with asthma, 4 with recurrent pneumonias, 2 with lung fibrosis, and then 4 needing oxygen therapy as well. Now, in their study, they concluded that their risk factors that they see these changes with include thoracic surgery, chest radiation, or both, and a shorter time since therapy, meaning when they looked, if you were longer out from your care, then you're less likely to have complications. If you're a shorter time, then it's possible you may. This kind of helps me transition and introduce a topic that I'm going to end with, and this is kind of where I became interested from a lung transplant standpoint. The mnemonic is PPFE. It stands for pleural parenchymal fibroelastosis. I'll identify that in just a second, what it means. It's a very rare but important complication that I think we're seeing more and more in neuroblastoma specifically. So PPFE, or pleural parenchymal fibroelastosis. So parenchymal kind of means the lung tissue itself. Pleuro means the area surrounding that lung tissue, kind of the area between the chest walls and the where the lungs end. Elastosis means basically like a rubber band or elastic tissue. And what happens is the body produces this elastic tissue, which makes it easier for areas to rupture in the lung, causing complications. And then fibro means the scarring or fibrosis. This involves progressive or ongoing scarring in the lungs of specifically the upper lobes. It was first described in adults in the early 1990s. Now, in the adults, it can be occurring due to, I guess the word is random chance. When we say idiopathic, or there's no other specific cause of it, and about 50% of adults have idiopathic forms. But in kids or long-term survivors, we see it as a secondary cause, and we tend to see it as a cause from radiation, from chemotherapy, or post-BMT. For whatever reason, we really don't know why, although we think it's related to some of the high-dose regimens of chemotherapy. We tend to see it a little bit more in our neuroblastoma population, both the TCH and then the referrals we get for lung transplant. So at our experience, TCH, and then I say ATS, which is our Thoracic Society national in North America, pulmonary complications of childhood cancer, there's a larger proportion of patients that had high-risk neuroblastoma. Now, to reassure everybody, the occurrence rate of this is low, likely between 1% and 5%. There we go. So the clinical features are very similar to what I described for all patients of things to be cognizant about. Shortness of breath with activity, decline in activity or lung function, dry cough, weight loss, chest pain. When I say pneumothorax, this is where that elastic tissue can cause rupture or air leak from the lungs, and that air leaks into that space between the chest wall and lung. And I have a picture of that I'll show you in a couple slides. The thing is, patients can have no symptoms for years, and so why I think it's so important to continue relationships with LTS and for asking you to go at least once a year is The patients we saw early on with this had symptoms, but then were lost to LTS follow-up at whatever institution they were at, and then presented later with very sick findings, that low lung function that we talked about. And at that point, when you're caught late, it's hard because the symptoms tend to rapidly progress. This is kind of what we see if you ever see this in your child or someone you know, where the chest wall, that's the breastbone that I circle in that image. The chest wall tends to kind of inward go. We call that pectus excavatum, or excavation, right? So excavatum, and you see this inward movement of the chest. If you see that in conjunction with someone who's losing weight or having more respiratory symptoms, that should be a referral to a pulmonologist. We're just starting to get the word out to other pulmonary groups. So that's why we have webinars and things like that, because a lot of pulmonologists are more, I guess the word's naive to this diagnosis as well. I first learned about it about 9 years ago, and that was just by random chance that we were talking to a pathologist who had just attended an adult meeting, who saw a slide of our patient who said, "This looks like something I just saw at a meeting." So it's luck sometimes, because that child's did well after lung transplant, but it's important that we get the word out. So that picture on the left is pectus excavatum. The picture on the right is kind of a deepened sternal notch, so that right where the neck is, you can kind of see that inward movement. That's more of a late finding, but if we ever see that, then I start to worry about this condition. Sorry, my slides aren't moving fast. One of the main things we see when we do lung CTs is that we see kind of inward or kind of narrowing of that front to back diameter. So this is a CT scan where a child's laying up. The top part is going to be the front part of the chest, the back part's the spine, the bottom part's the spine. And so we see the first, this is the same child, the first CT, it's actually pretty normal kind of front to back diameter. And the second CT is with advanced disease. We see this narrowing of the front to back diameter. We also see that dark black on each side, and then it's starred on the picture on the right. That's that pneumothorax, or air developing around the lung, basically. And those tend to be with advanced disease as well. We have noticed quite a few patients with this at our institution, both internally and then on referral. So we've had now 12 patients with PPFE identified from 2012 to 2020. 8 of those 12 actually had high-risk neuroblastoma. And again, we think it's likely related to the high-dose cyclophosphamide. We see that in other patient groups as well. All patients of our group had significant weight loss. Most had trouble with gut movement, and so that led to significant nausea and inability to tolerate food, and needing feeding tube to help with gaining weight. And most of these patients presented well after their cancer treatment, 5 to 7 years. I know I was talking to Pat before the conference about, it sounds like you guys may know someone that has been through undergone a double lung transplant. And my gut feeling is this is probably what they ended up having, although it was probably under-recognized at the time that they went through this. Sorry for the small print, but that's a paper we published back in 2019, our first 8 patients with PPFE. And we kind of look at their prior cancer that led to the injury of the lung and needing lung transplant. And 4 out of those 8 patients had neuroblastoma and high-risk neuroblastoma, all of which had really, really poor lung function when they came to us. They had very advanced disease and needed all the things that we talked about in the previous slide. Unfortunately, there's not good treatment that's been identified for this disease at this time. What I underlined is what we currently do for our patients. There's 2 commercially available anti-fibrotic or anti-scarring medications. There's about to be a third that are used. I've used them to variable success myself, and that's what's reported in the literature, about 50-50 success. The current 2 patients I have with PPFE, one with neuroblastoma, actually are doing well and stabilized. They're able to do activities that they enjoy, play basketball with their friends, are able to go for exercise with their family. The other thing we've done for them is incorporate pulmonary rehab programs for them. So when we when they come to our clinics, we write a referral for pulmonary rehab. They get trained on different exercises they can do for rehab, which relates to endurance and resistance training. And then also we put them on nutritional support if needed. So either appetite stimulants or an NG tube to help with, or supplementation orally to help with their weight. Now, for patients that continue to progress or are discovered late, unfortunately, we do get referrals for lung transplant. Lung transplant, I didn't talk about at all, but that has its own sets of challenges. That has its own sets of kind of survival outcomes that I'm not going to get into right now for the purpose of this talk. I gave my email address at the end. Feel free to email me if you have questions. I will say for our pulmonary complications of childhood cancer group that is referred to lung transplant, we hit another kind of challenging roadblock when it comes to the emotional side, the psychosocial side. I don't have to preach to this room, obviously, because I've been through a lot, right? You've been through the whole having to uproot your family to a different institution. You've been through being in the hospital. To have to go through that second time can be challenging two different ways. The first way is the thought that, and I'm guilty of this if anything happens, it's why me again or why our family again, right, for a second time. Because lung transplant has its own, there's not many lung transplant centers in the country. You do have to relocate for a certain period of time while you wait for your lung transplant and afterwards as well. The other group of families that I meet that have this tend to say, we've already been through something, we got through it, we're gonna get through this just fine. And it's unfortunately not as easy in lung transplant. You have to be vigilant about what you're doing every time. If you miss one small thing, it can cause changes in how your graft is doing. So I just kind of mentioned that. So I have all our patients see Child Life, obviously. I have all our patients see our chaplain, our palliative care group, and our psychologist to kind of get that process rolling even before we get on someone on the list. For PPFE, there's this kind of two-peak aspect of the disease where some patients really do progress really quickly, and it's tough to get them stabilized, and they get referred to lung transplant. And some have a very, very slow course. That's why they're not recognized quickly and can survive 11 to 15 or more years without much in a way of intervention. Again, I think this is very small in terms of its incidence or in terms of how often it occurs, but I think it's very important because specifically we're seeing this for this neuroblastoma group of kids. The key is to stay vigilant, going to your long-term survivors, noting any changes that are occurring. And so what do we do in our pulmonary evaluation of long-term survivors clinics? We do lung function testing. I think CHOP has a pretty good collaboration with Pulmonary and their long-term survivors. I've identified which patients I think I need to see to our long-term survivors, so I have a good relationship. I've given talks to them. They've given talks to me. We kind of just have an idea of when we're going to get referred. And we have a group of pulmonologists that tend to see our kids that are long-term survivors in general. We do a pulmonary function test, which I mentioned. We do a 6-minute walk test, which purely involves someone walking 6 minutes and comparing how far they walk relative to population that's the same age, height, and gender. We at the same time we keep a heart rate monitor and a pulse ox on them to make sure they're doing well. Any patient that I notice that is starting to have decreased saturations, I put them on oxygen therapy. That I think does help in terms of work of breathing. Obviously, in your LTS, you get blood work, and so we sometimes ask for blood gas. Sometimes you'll get chest CTs if the lung function's changed. And occasionally, if that progresses, we consider a lung biopsy. I will say for this group of patients I just talked about, I don't recommend lung biopsy because that's what can lead to that persistent air leak as well. When does the pulmonologist or when do I personally get involved? I tell our LTS group that if you see any changes in a CT scan or a decline in lung function greater than 10% with specific patterns, then I want to at least see that patient once, and I usually try to follow them at least yearly when they go to LTS. Obviously, I do ask that our patients stay vigilant if there's any change in their activities. As an example, they can't run like he or she used to. So I just want to summarize and conclude with saying what do we know and where we're headed. So what do we know? We know that pulmonary complications are infrequent, but can occur. We know that surveillance through LTS, through lung function testing, is going to be important to maintaining that good health. And there are diseases that are more specific to complications of the chemotherapy. Fortunately, they're rare, but they're very important when we hear about them. Where are we headed? Again, I think across the country, pulmonary groups partnering with LTS is going to be very, very important. I think the awareness from even our pulmonologists about specific problems, the rare that you see something, it's going to be concentrated in certain places like CHOP, like bigger institutions that are in bigger cities. So I think it's important to make aware, to create awareness. And the oncology groups too. I think that's why partnering LTS and pulmonary is going to be important. We're going to create, nationally, we're going to create a registry or database for patients with PPFE to kind of see what the true occurrence rate is in neuroblastoma, to kind of see how many of those patients with PPFE were neuroblastoma survivors. And then research from our side in the form of tissue banking, discovering biomarkers for disease progression. What can you do? I think the most important thing is continue to attend your long-term survivors clinic. Educate, on pulmonary problems. I mentioned that slide that I think is the most important. Just kind of identifying symptoms that are changes is going to be so important. Notify your medical care team if you have any of these things that are listed right there. And then, of course, live your life, but then please be vigilant at the same time. And then with that, I'm happy to answer any questions.
Thank you, Dr. Das. We have a question? Go ahead.
Okay, I'm kind of short, so hopefully you can hear. I am going to ask a general question, but I want to start with some specifics to provide context. So my son was diagnosed 6 years ago. He's been in fairly constant treatment with just having his third relapse. So this is his fourth round of treatment. And so my generalized question is, when do you start going to a survivor's clinic? And then for children like my son who have sustained multiple relapses, when do we start asking these kinds of questions? He has some shortness of breath that we've noticed over the last maybe year and a half. Exercise is a little bit more difficult, when he can do it. So that's kind of my question.
I can answer the second part of your question. Well, I think the first part of your question might be answered by members of this group quite nicely, so I'm going to maybe defer that first part, and I'll come back to it. The second part, I think that if a child's able to do lung function, there's multiple things when I say if. Being a certain age, so the cognitive ability to know how to do lung function testing. There's games that we play with our kids. They can blow out candles. They can try to have a bowling ball, knock down pins. Because you have to be able to forcefully blow, and that forceful blow comes with those games, if that makes sense. Your child can do lung function testing at any point in the progress. So during care or after care as well. If someone's acknowledging that they're having lung symptoms. Getting a CAT scan is a possibility. I think the first step may be just to ask your team if they feel, because of the symptoms that your child has, to see a pulmonologist either in the hospital or in the clinic. And then working with physical therapy or any kind of person that could help with, not only from a muscle strength standpoint, but also an endurance standpoint, can be beneficial as well. The first part of the question when it comes to survivorship, I think some of the people in the audience probably can answer better than I can when they started going to. Yeah.
We're going to go over here to
Sure.
that question.
Okay, so we had done you had mentioned the high dose cyclophosphamide and thoracic surgeries as being a high risk factors for that.
Sure.
Well, is there a difference in like the radiations between like the photon and the proton for like scarring? And then how often do you recommend doing the pulmonary tests?
Yeah. I think when it comes to, we were talking about radiation dosing yesterday and the type. I think for my standpoint, I look at, yes, it does matter, but I think the biggest deal is location of radiation. So if you have thoracic radiation, I think you're at risk. I think that's the key. I think that at least getting a baseline lung function would be good. probably every 6 months to a year. Now, if there were symptoms that led you to get lung function testing for a different reason, then maybe every 3 months, maybe that for that first year, and then after that, every 6 months to a year once you're stable. But usually for most patients, I recommend at least every 6 months.
So once therapy ends.
Yeah, exactly. That's what I tend to say. Again, some of the patients we follow had it before they went home. Finished their care. I think of the patients that are referred to us. And so I would do it like maybe if you're following a pulmonologist for a different reason early on, then maybe every 3 months to start with. And then after you're stable, maybe every 6 months. If you've never had to see one, then your LTS should drive that. But I'd say at least once in the first year of seeing your long-term supervision.
Okay, we'll go here and then we'll go to Deborah.
Sure.
I just wanted to thank you for inviting Dr. Das. Thank you for being here. This is actually a question that our family has had for a while. Our daughter was diagnosed 9 years ago. She's relapsed once, but she's been clear now for 5 years. She started having breathing issues pretty soon after starting treatment, and she's had kind of constant shortness of breath, when she's just kind of standing around and she'll have to sit down and breathe. But it's been consistent. So I know that you focus on a specific condition that's maybe more serious, but I guess I have a couple of questions. The one is, are there other conditions that tend to crop up that are more stable? A lot of our kids will have high blood pressure, but it's easily treated by medication. So that would be my first question. And then my other question would be, we've mentioned this, at several appointments over the years to different doctors. What is a good way to make sure that if we see a pulmonologist who might not be familiar with children who have had high-risk neuroblastoma treatment, what are good ways for us to make sure that they have the information they need to do the appropriate tests?
Yeah, that's a great question. Both are great questions. The first one I'd say, I think that there are a number of things beyond just the rare that can occur. I think that it's good to kind of have that same workup in mind. So getting lung function, kind of defining, is this more obstructive, like asthma-like disease, or is this related to kind of restrictive, or is it even sometimes, like I said, muscle weakness can relate to this, right? You've been through care, you've been in the hospital a long time. So I, as an example, was in the ICU a few years ago for days on end and had to go through rehab myself. And so it's the same kind of concept of just kind of building back. So time progression of what's going on is one thing when it comes to the more common things even, and kind of seeing how you respond to rehab and getting that workup and how is that changing over time as well. I hope that answered that somewhat. But yes, there are other causes. The second question that you ask, this is a challenge that we have, I'd say, everywhere when it comes to, like I said, I was lucky to learn about this because, the timing of showing the slides to the right person, et cetera, et cetera. I think that when I say be vigilant, I think it means related to, okay, I'm seeing a pattern that doesn't make sense. The doctor's saying it's the same thing over and over. Maybe it's time to seek another opinion and ask that doctor in a nice way, hey, there are centers that see a lot more pulmonary complications. So I think of CHOP because I partner with them a lot at Texas Children's. I think it's us because I work there. But there are bigger centers, sometimes because there's that relationship with LTS in some centers that you may want to just ask for another opinion. Yeah.
My question's kind of like hers. My son, he battled for 8 years. He's now 15. He was diagnosed at age 2, and he battled several relapses. And during his relapses, he was a preemie twin, so he already had damaged lungs when he was diagnosed, right? So during all this treatment, his lungs, I guess they classified him as he had asthma. And then right now that he's been 5-year cancer-free, and they just tell me, oh, he has damaged lungs. He's always going to have damaged lungs. And when it came back on his lungs. He has like nodules. To this day, the nodules are still there, but they're just like dead, I guess. Now, my worries for him is like, he's 15 now, but in the future, like, how will this affect him? Or does like pulmonary failure occur years later, even after being 5-year event free,
Yeah.
So I'm just like worried about his future. Like he's a survivor right now, but And that picture you put about the lungs, like he has like a protruded lung on the right side because of the radiation he received when he was 3 years old. So I worry about his lungs, and I every time he gets like checkups and stuff, the response from the doctor is like, "Oh, his lungs are stable. He'll always have damaged lungs." And I'm like, to me, that's like, oh, I'm worried about that, because what does this mean for his future?
Sure. I appreciate that question. That's a tough one, right? When you have this kind of baseline of, oh, we expect him to have preemie lungs for a long time. I think that part's true, to your doctor's credit, in saying that, yes, you're at a different baseline than a child that was born on time. That being said, you add another layer because of the therapy that kept your child alive, right? And that's important to acknowledge for yourself and your doctor, like you're saying. I think that the best way I could recommend going forward, it would be to say, okay, we have this. He does, he's able to run 5 minutes with me, or whatever the activities I like to do, and his lung function, if he's able to do lung function, is this. Please let me know if you feel something's changing in his lung function. Then now what I actually tell patients is to request a copy of every one of their lung function tests as well, because you can always get a copy and just save a binder full of them, and then you start to notice the changes too. Then you can say, this shouldn't be happening, because preemie lung disease usually gets better over time, right? And so if something was happening the opposite of that, then you would start to think maybe this is related to the cancer therapy.
Should some kind of pulmonary test be done yearly for like?
That's what I usually recommend. That's what I recommend for all LTS clinics. Yeah, I think it's the subtleties of not being able to know symptoms, like patients are asymptomatic, in other words, that at least the objective test, that lung function, could be beneficial.
Yeah, because I feel like once they hit the 5-year mark and he's like, passed out of the woods, right? We focus on other things, and then I don't think we even think about pulmonary anymore.
Yeah.
But I do.
No, you're right. And I'm selfish. This person right here is the only pulmonologist, so I say everybody should get LTS, lung function testing. But I do think it's important from a global standpoint of those subtleties and changes may be important long term.
All right.
Okay.
Because we'll do our last question. Sorry, Frank, because we're past.
Yes.
No, she's got the last question. Oh, okay. All right. Yeah, because we're running short.
Again, thank you for being here. My daughter was actually born with neuroblastoma, so it was undiagnosed at birth. So we have no one to really compare her problems to. So she was born on her due date. She was healthy weight, healthy length. Everything was very healthy about her. She does have a lot of wheezing. She has a lot of stridor, deep retracting. She's had that her entire life. To me, that's her baseline. That's what we've always discussed. That's her baseline. That's her baseline. Even the volunteers in the other room right now are like questioning her labor breathing. Is she okay? To us, she's fine. We see ENT about possible scar tissuing from she was intubated for 6 weeks after birth, and then vocal cord paralysis from the intubation. We've never really discussed the lung or pulmonologist's point of view. We did have to see a pulmonologist just to get a sleep study done, which came back fine. Mm-hmm. But now all of these are bringing up all these other questions. She did get an x-ray when she was sick probably like 5 months ago. Is an x-ray different than a CT scan? Is there something that can be done? She hasn't really entered survivorship program yet. She will this year when she turns 4. She's 4 now, but she'll enter in August. So is there other testing that should be done? Because she does have pulmonary problems, and I mean, she's very noisy, very noisy. So, if I don't hear her in a store, then I'm concerned.
Yeah, no, you bring up a good question as well in terms of what to do. So we usually say reproducible lung function testing is done about the age of 6. So that means kind of where you're more accurate would be about 6 or above. So that toddler age group is really challenging in that sense. And you have no thing to compare it to, like we were this way before and now we're this way after, right? So I think the biggest keys, I would say, start with what you know already. So ENT you're going to, and they're going to do surgery. Let's see how things change after, if they're going to do any surgery. So there's a couple different options they have for a unilateral vocal cord paralysis and for some narrowing of the airway. Let's see if anything needs to be done. Start there. Start going to pulmonologists. Yeah, I think that's fine. I think there's not a lot that objectively that you're going to say other than weight. How are we easily able to gain weight, by just doing our usual diet versus having a challenge in gaining weight? Then you kind of start to say, okay, maybe our lungs aren't good. An X-ray is different than a CT, so I think starting with an X-ray is totally fine, and we get X-rays on everybody too. And in fact, insurance companies dictate when we can get CT scans now. CTs give you a little more 3D anatomy and more delineation. They help with that scarring question that I talk about and stuff like that. But I think X-ray starts the process. I'd say the biggest factors are how we gain weight to start with, and how we're growing and developing at this age.
Okay, is that it? Okay. All right. Thank you, Dr. Doss.
Thank you.